Hello guys, I am Dr. Vishnu and today I am here to share with you my practical knowledge insights on drug metabolism. In part 1 of this video, you already saw a lot of headings. We described the mission of our channel. We talked about phase 1 and phase 2 metabolism. We talked about drug induction and inhibition, enzyme induction and inhibition, etc., etc. So now we will be talking about prodrugs and many other interesting aspects. So always we talk about the mission of our channel. As we said, the mission of our channel is to make sure that practical knowledge that is very tough to understand or very tough to derive, we make it in simplistic terms. So we believe that we have to work smart because everybody is working hard. Now we have to be a bit different and we have to work smart. Welcome to an ocean of practical knowledge. So according to the previous video that you saw, we talked about general introduction. We talked about phase 1 metabolism. We talked about phase 2, enzyme induction and inhibition, and drug interactions due to metabolism. Now we will be talking about prodrugs, which are the different drugs metabolized by cytochrome P450 enzymes. It will be in a tabular presentation. What are some interesting catch points and definitely mnemonic time. So we had a general introduction in which we said that the liver is the primary organ for metabolism. Then we talked about phase 1 metabolism where we said that it is mainly applicable for prodrugs because it is converted into active form. The most common reaction is oxidation. Then we decoded the meaning of cytochrome P450 and what are the meanings of individual enzymes. Then we talked about phase 2 metabolism, in which glucuronidation is the most important. We talked about the association of Klippler-Najjar syndrome with glucuronidation and how it can affect the metabolism of some medicines. We talked about some examples, enzyme inducer and inhibitor. We talked about some drug interactions. Now we will talk about prodrugs. So prodrug usually refer to inactive form of drug. They enter into the body. Phase 1 metabolism breaks down that molecule, adds a functional group and makes it active. So prodrugs are those molecules which are inactive outside. When they enter into our body and get metabolized, they get converted into the active metabolite. In some conditions, prodrugs are purposefully made also. So they are made in those kind of formulations purposely so that it increases the lipid solubility and also enhances oral absorption. Now we talk about the drugs that are metabolized by cytochrome P450 enzymes. All the names of the cytochrome enzymes are not mentioned here, that you can refer personally. Some of the enzymes have been mentioned here. So in this table, you will be seeing the different cytochrome enzymes, which are the molecules that are metabolized by that particular enzyme, which is the molecule that induces that particular enzyme, and which is the molecule that inhibits that particular cytochrome enzyme. So the first is CYP3A4. It is the most common. So it is metabolized by cyclosporin. Cyclosporin is an immunomodulator. Calcium channel blockers are metabolized by CYP3A4. Tacrolimus is an immunosuppressant. Statins, they are used in hyperlipidemia. And amiodarone is an antiarrhythmic. Now the molecules or the drugs that induce CYP3A4 are barbiturates. They are sedative hypnotics. Rifampin, it is an anti-tubercular agent. Phenytoin, it is an anti-epileptic. And carbamazepine is also an anti-epileptic. The molecules that block CYP3A4 are erythromycin, which is an antibiotic. Ketoconazole is an antifungal agent. Fluconazole is also an azole antifungal. Ritonavir is an antiviral agent which is used in HIV and grapefruit juice. Then we come to CYP2D6. Most of the antidepressants like SSRI, selective serotonin reuptake inhibitors, tricyclic antidepressants, and MAO inhibitors are metabolized by CYP2D6. And most of the beta blockers and antiarrhythmics also are metabolized by CYP2D6. There is no particular inducer that has been found till now for CYP2D6, but yes, we have enzyme inhibitors. That is quinidine, it is an antiarrhythmic, and paroxetine, it is an SSRI. So here you can understand the irony that there is a SSRI which is metabolized by CYP2D6, and there is another SSRI, that is paroxetine, which blocks CYP2D6. So this is very interesting. Now we come to CYP2C19. So the substrate, that means it is omeprazole and clopidogrel. Omeprazole is a proton pump inhibitor, and clopidogrel is an antiplatelet agent. It is metabolized by CYP2C19. Rifampin and barbiturates are the inducer, and fluconazole is the inhibitor. CYP2C9, phenytoin, tolbutamide. Tolbutamide is a first generation sulfonylurea used in diabetes, and warfarin is a anticoagulant. Inducer is again rifampin and barbiturates, and inhibitors are erythromycin and cimetidine. When we come to CYP1A2, theophylline, which is a bronchodilator, and warfarin. And inducer is smoking and rifampin. So if a person is a very chronic smoker or is having a habit of smoking, then theophylline is not a very good option. Inhibitor is ciprofloxacin. So it is a fluoroquinolone antibiotic. CYP2E1, paracetamol is metabolized through this. Enflurane and halothane are actually general anesthetics. Inducer is ethanol. So that is why when you take ethanol with acetaminophen, it increases the risk of hepatotoxicity. And inhibitor is disulfiram. It is an antidote for ethanol addiction or alcohol addiction. So now what you can do is, you can take a particular substrate and you can take a particular inducer or inhibitor, and you can check in your Medscape or any drug interaction website and try to find out whether there is an interaction or not. And then you can make your own notes and you can study accordingly. Now we come to some very interesting catch points that can be seen regarding drug metabolism. Omeprazole is a very interesting molecule. It is an inducer of CYP1A2 and it is an inhibitor of CYP2C19. So that is something interesting about omeprazole. If you are an acute alcoholic, that means if you have taken alcohol in a large amount at a very short time. So that is the difference between acute and chronic alcoholism. Acute alcoholism means in a particular moment you are taking large quantity. And chronic alcoholism means you are taking little quantity for longer durations. So in acute alcohol consumption, it causes enzyme inhibition. And in chronic alcohol consumption, it causes enzyme induction. So now you can understand what can be the different drug interactions that can happen. And that is why whenever you see most of the medicines, it is always advised to avoid smoking and alcohol with that. This is the reason. Especially for alcohol, this is the reason. Now, this is the last part of the topic. It's mnemonic time. So there are a lot of mnemonics that I would like to share with you. I have referred some books for that and I found it very interesting. So I thought that this can help in, you relaxing a bit and enjoying the mnemonics and remembering in your own way. To remember the name of phase 1 reactions, you can try the mnemonic OR-CHART. Anyways, you know what OR-CHART is. So here R is not there, but OR-CHART. O stands for oxidation, R stands for reduction, C stands for cyclization, H stands for hydrolysis, A stands for aliphatic and aromatic hydroxylation, and D stands for deamination. So this is a mnemonic that you can remember. To remember the names of phase 2 reactions, you can remember the code GAMES. So here you can see very carefully that the E is mentioned in small letter because we don't have a particular E type of reaction here. So we can remember the code GAMES. G stands for glucuronidation, glutathione and glycation. A stands for acetylation. Me stands for methylation, and S stands for sulfation. To remember the names of prodrugs, you can try the code. All prefer doing MD in clinical subjects. So you can watch it very carefully. I have used capital letters in very selected areas, and wherever it is in capital, it means it is a mnemonic. All A stands for ACE inhibitors. All ACE inhibitors are prodrugs except captopril and lisinopril. Prefer the P stands for prednisone, which is a steroid, proton pump inhibitors, and proguanil, which is an anti-malarial agent. Doing D stands for dipivefrin. M stands for mercaptopurine, methyl-dopa, minoxidil. D stands for dopamine precursor, that is levodopa. I stands for irinotecan. Irinotecan is an anti-cancer agent. Clinical, C stands for cyclophosphamide, clopidogrel, carbimazole. Carbimazole is used in hyperthyroidism. And subjects, S stands for sulfasalazine. Sulfasalazine, you know very well. It is a very powerful prodrug. When you study inflammatory bowel disease, you will understand the reason why. To remember the name of enzyme inducers, the molecules that activate enzyme to a greater level, try the code GPRS cell 4. G stands for griseofulvin, P stands for phenytoin, R stands for rifampin, S stands for smoking, Celca C stands for carbamazepine, and Phones P stands for phenobarbital. To remember the names of enzyme inhibitors, you can try the mnemonic. Vitamin K cannot cause enzyme inhibition. Once again, please look at the capital letters carefully. The capital letters are the ones that we are going to talk about. V stands for valproate. K stands for ketoconazole. The C of cannot stands for cimetidine. The C of cause stands for ciprofloxacin. The E of enzyme stands for erythromycin, and the I of inhibition stands for isoniazid. To remember the name of drugs that are metabolized by cytochrome P3A4 enzymes, you can try the code CT scan. Obviously, there are so many medications that are metabolized through CYP3A4, but these are some of the selected drugs with which we can make a mnemonic. C stands for cyclosporin, calcium channel blockers. T stands for tacrolimus. S stands for statins. C stands for cisapride, which is also a prokinetic. A stands for amiodarone, and N stands for navir. Actually, the protease inhibitors end with navirs. So we have ritonavir, atazanavir, etc., etc. So N stands for navirs. That means they are protease inhibitors used in HIV infection. So that's it for this presentation. I hope you have enjoyed the part 1 and part 2 lectures of drug metabolism. This has completely been practical approach. Theory approach you will get in books and notes. I hope now you have got a better insight into what drug metabolism is and how relevant it is for our clinical practice or memory or for practical knowledge. If you have got sufficient amount of information from this, then please do like, share, and subscribe. Share it to maximum people, because I believe that this kind of videos will definitely help a lot of people who are good in academics, but somewhere struggle with their memory or with remembering things in the practical perspective. Thank you so much. With due humble regards, I sign off for today. We'll come back with an interesting video the next day. Until then, it's bye.